I'm Victor Roy. I'm a physician and a sociologist, postdoctoral fellow at Yale, so zooming from New Haven, Connecticut in the US. And I'm excited to moderate this discussion, this paper session that is titled Givers and Receivers, Entrepreneurial Business Ethics and the Moral Economy of Health and Medicine. And so 3 papers, each kind of distinctive cases to explore. We'll have about, I'd say, we can kind of go like 20 or so minutes for each paper. Then we'll have plenty of time for discussion and the dialogue at the end. So the first paper, Larry Au will present long COVID in Brazil and the United States. And then Benjamin Hunter will share his paper, Moralizing Internationalization in the English NHS. I think I got the most recent title right. And then Anne Moyal. How do you pronounce your, I'm not sure if I pronounced your last name correctly.
Moyal, yes, it's okay. Thank you.
Implementing primary care reform in France, bargaining power dynamics and policy adaptation, the case of multi-professional healthcare centers. So I think we can get started, and if each person wants to introduce a little bit more about themselves, and feel free to do so, or just jump into the papers.
Sounds good. I'll share my screen and kick us off then.
Yeah. The only other thing I'd say is, since there's only two other folks, it might be great just because I haven't met Etienne and John and Chang. We could even just hear from them briefly about where they're zooming in from in their background. Etienne, do you want to just introduce yourself?
Okay. I'm Etienne Noguez. I am an economic sociologist in France, and I work on medicines markets, and I'm co-organizer of this mini conference with Larry Wanzilou and Catherine Ibata-Arens. And if you're not aware, we will become a network next time in SASE. Woo-ha!
Exciting. John?
Hi, I'm Chang. I'm a PhD student at New School for Social Research. I'm also part of Larry's research in long COVID. Yeah.
Awesome.
Nice to meet you all.
And then John, do you want to?
Sure. Yeah. Hi, everybody. My name is John Schaefer. Good to see some familiar faces and new faces. I'm currently a postdoc at Johns Hopkins in the Berman Institute of Bioethics, and am moving up to Burlington, Vermont, to start an assistant professor in sociology job there. And I'm interested in, sociology of health and illness and science and technology studies, and excited for this panel.
Thank you. Well, Larry, take it away.
I will do that. All right. I'm going to try to full screen the slides and let me know if you cannot see them. All right. Can you guys see my screen? All good? All good?
All good.
Yeah. So the paper that I'm presenting today is called Long COVID in US and Brazil. It's somewhat preliminary findings from an ongoing research project called the COVID-19 and Trust in Science project. I'll give a little bit of background on the team. Chang is one of the team members on this research project, and there are others as well too. But this project is housed out of a newly launched center at Columbia University called the Trust Laboratory. It's based out of the Insight Institute, and its founding purpose is to promote ways to think about how to better structure relationships between patients, doctors, and scientists to create more collaboration, create more ways in which different stakeholders can trust one another. And these are some of the team members. There's a lot more as well too, Chang being one of them. But it's the center is run by Yale, who's the director of the Trust Laboratory, Christian Capitesco, who's the associate director, And specifically today, I'm presenting findings from our Brazil arm, which is helped coordinated by one of our collaborators, Renan Gonçalves Leonardo Silva, who is a postdoc at ETH Zurich in health policy and ethics, and also our very, very capable research assistant, Amanda Curry, who was a research consultant for us. If any of you folks ever need work that's being done in Brazil, feel free to reach out to Amanda. She's always very capable and very willing to help with different projects. So broadly, what is CATS interested in? The COVID-19 Interest in Science project. We're broadly interested in processes of recovery with COVID-19 and long COVID, recognizing that it's a very long journey for many of the folks in our interview and survey samples. We're interested in particular how patients deploy strategies to identify trustworthy forms of information, particularly when a lot about what we know about long COVID is contested and uncertain. So how do patients create alliances with scientists? How do they create alliances with one another in order to sort through potential misinformation, potential snake's oil in areas of treatment for long COVID? We are also interested in broadly cross-national experiences and how social contexts, how national policies, how healthcare institutions, healthcare systems shapes the manifestation and management of long COVID. And we are interested in also creating recommendations for policymakers and medical professionals so that they can better serve this emerging patient population. So for some of you who might not be as aware of what long COVID is, this is a working definition of long COVID that was developed by the US Department of Health and Human Services. It's an interim definition. It's a definition that's currently being workshopped by the National Academies of Science, Engineering, and Medicine. There's a working group that was convened a few months ago that is doing actually really good work on stakeholder engagement and convening different patient groups, scientists, clinicians, and different advocates to see how this definition might potentially impact things like the ability of patients to get a diagnosis, to things like workplace accommodations, potential ramifications for insurers, disability, et cetera. But this working definition so far says that long COVID is broadly defined as signs, symptoms, and conditions that continue or develop after initial COVID-19 or SARS-CoV-2 infection. The signs, symptoms, and conditions are present mostly for 4 weeks or more after the initial phase of infection. They may be multisystemic, may present sort of relapsing, remitting patterns and progression or worsening over time, with the possibility of severe and life-threatening events, even months or years after infection. Long COVID is not one condition, it represents many potentially overlapping entities, likely with different biological causes and different sets of risk factors and outcomes. So it's a broad term meant to encompass the wide range of experiences that long COVID patients typically have. This is a diagram from a recent review from patient researchers, Hannah Davis, Lisa McCorkle, Vogel, and Topol, that kind of gives an overview of the different types of long COVID symptoms and the impacts on different organ systems and different pathologies. So some types of long COVID have like primarily cardiovascular symptoms, things like POTS, similar to things like POTS. There are other long COVID patients who potentially suffer from more neurological symptoms. So a lot of chronic fatigue symptoms like chronic fatigue syndrome, a lot of things like brain fog, severe fatigue, memory loss, et cetera. There are others who have more respiratory systems, difficulty breathing, et cetera. So it's a vast array of symptoms that researchers and patients are gradually trying to refine the categories, refine the different subtypes of long COVID. But I think the way to think about long COVID as a label and as a term really is a way for patients to demand attention. It's a strategy, it's a repertoire, it's a tactic to name a condition in order to lobby for more attention from funding, from policymakers, and from medical professionals, et cetera. So a little bit of long COVID by the numbers. There's a lot of different studies and meta reviews and systemic reviews. The estimates of long COVID incidence ranges from 10% to 25% of people infected with COVID-19 develop some form of long COVID. Again, there are a lot of different symptoms, so it's a large estimate. It's a broad estimate of anyone who has these lingering or new symptoms that emerge from COVID-19 infection within the United States. These are surveys from the U.S. Census Bureau from the Household Health Survey analyzed by the U.S. CDC in March 2023. The most recent estimate was that 1 in 10 adults suffer from some form of self-reported long COVID. So that's a population of about 36 million. There are no available estimates in Brazil of the size of the long COVID population, but there have been over 37 million infections over the course of the pandemic with 700,000 deaths. So we take this like rough like estimate of 10%, like the lower bound of it, about 3 million, 4 million folks in Brazil potentially have some symptoms of long COVID. So still a very large patient population. There's also an emerging sociology of long COVID. There's a lot of folks who are working on this issue, and there are a lot of different teams who are doing really good research on the experiences of patients with long COVID. This largely draws from the literature on contested illnesses from folks like Joseph Dumit, Kristen K. Barker, Joanna Kempner, Abigail Doones on how a lot of illnesses like ME/CFS, post-Lyme disease, fibromyalgia, have some form of contestations between the legitimacy and the reality of these diseases between patients and doctors for reasons such as unclear biomedical mechanisms, the etiology of disease, unclear boundaries of it, the inability to establish the causation between these different symptoms to an actual biomedical cause. So there's a lot of contested illnesses that kind of overlap with a lot of what long COVID patients are experiencing. Long COVID, as I mentioned, is a patient coin term that's tied up with a lot of advocacy and online information sharing at the early phase of the pandemic. So thinking about the end of the summer of 2020, when a lot of patient organizations and forums started to pop up online on places like Reddit, Facebook, etc. So there's a lot of self-organizing involved in creating this term long COVID. There is also a huge gender inequality and linkage towards the psychiatrization of women's health complaints before long COVID. This is also reflected in our most of the estimates of the patient characteristics of long COVID patients. About 2/3 of self-identified long COVID patients typically are female. And this is also true in our interview and of our survey samples for the study. Most of our interviewees are also women as well. Patients have also mobilized the rhetoric of medical gaslighting to point to their experiences of dismissal, diagnostic delays, and the lack of treatment options for them. And there's also been a lot of patient support groups that are still providing a lot of critical supports amidst these uncertainties that are faced. Other sociologists have also written about the other possible reasons for the ignorance of, quote unquote, ignorance of long COVID and diagnosis, from things like causal agnosticism, so the inability to attribute all these symptoms to COVID-19 initial infection, to the lumping of similar conditions with long COVID, or even the segmentation of all these different diverse symptoms into different subgroups, making this long COVID diagnosis as a less stable entity. There's also a lot of patient guides and patient-led research in this area. There's a lot of really good books written from patient perspectives that are also good to consult with. All right, so a little bit of our project timeline. Our interviews were done primarily for the US sample in the fall of 2021. I'll talk more about the survey demographics in a bit. So this was done in fall in 2021, and the Brazil survey and interviews were conducted in spring of 2022. This is important because I think a lot of the particularly more egregious examples of dismissal or the more negative patient experience were primarily reported by folks in our US sample who were infected with COVID-19 early on, perhaps like in the first wave in March of 2020. So they developed long COVID relatively early on by the end of summer or late in the fall of 2020. So they were experiencing this at a time when there wasn't a name for long COVID. There wasn't as much awareness of the potentials for prolonged symptoms, et cetera. Our Brazil survey came a little bit later on. So this might also be reflected in what we find. There might have been a little bit more awareness of long COVID or post-COVID sequelae compared to our US sample. We also conducting interviews. We're conducting interviews in the spring, this past spring in 2023, with Chinese respondents thinking through how changing public health guidance, particularly at the end of zero COVID policy at the end of 2022, impacted the way that people thought about the threats of COVID-19, how they think about COVID-19 as no longer a life-threatening disease, and how that impacts how they think about long COVID. And Chang, who's in the audience, is doing good work with that. All right, so some of our characteristics of our survey subsamples. This is a table 1 of our US sample. So we had 334 respondents on our surveys, and they are primarily female. 75% of respondents are female. They're primarily white, 76%. They are also quite highly educated. Most of them have completed college or have a graduate degree of sorts. In our interview sample, we also see a lot of folks who are professors, who are doctors, who are nurses, who are in PhD programs, et cetera. So this is a slightly, definitely a biased sample. There are also majority full-time or part-time employed. One of the things that we wish we did was to have like a disabled category in our employment response. They are primarily suburban in the US and also are of higher incomes, above minimum wage, 38% reporting above 100,000 for household income, and they're primarily liberal Democrats. These are characteristics of our Brazilian long COVID subsample. So we had 144 responses for our survey, and they're also primarily female, primarily white. They also are very highly educated, majority completed college or have some form of graduate degree. They also are primarily full-time employed, primarily urban compared to suburban, and they also make above minimum wage, which is 1,100 real. They primarily identify as independent and other, so a little bit different from our US sample. All right, so going into the findings. So one of the things that we saw primarily from our US respondents was invoking this term gaslighting. This is a rhetoric that is invoked frequently by our US respondents to talk about how they were dismissed by doctors when they were bringing in these symptoms, when they were talking about their concerns with medical professionals. Gaslighting is a term that refers to the denial of the reality of these respondents. So these are some quotes from our US respondents: gaslighting, more gaslighting, literal laughing for medical providers. The second quote here is, in the beginning, it was terrifying. No one believed or understood that COVID lasted longer than 2 weeks. It wasn't a life or death thing. At the most terrifying point of my life, I had to fight not just to live, but for people to believe that my illness existed, let alone to get help, because COVID is only a respiratory disease and lasts maximum 2 weeks. So there was the initial respondents that we had in the US combated a lot of misunderstandings, combated a lot of lack of awareness of the potential for COVID-19 lasting more than 2 weeks. And as I noted before, there is a highly gender dynamic. This is something that our respondents also noted as well too. There's a lot of awareness of how women's health complaints are potentially dismissed by male medical professionals. And these are things that were brought up by our respondents as ways of understanding their own interactions with medical professionals. These are some of our quotes from our Brazilian respondents. Our Brazilian respondents didn't really invoke the term gaslighting as much. I mean, it could be a thing of translation, but potentially a different type of repertoire or script that is relied on by folks in Brazil to make sense of their own experience. But they still reported a lot of experiences of dismissals from medical professionals. So these are some quotes. The doctor said that there was no assumption that my headache was because of COVID. He said that I had no problem, that I should just stop spending too much time on the computer, presumably like researching their condition, et cetera. At first, they said that it could be linked to anxiety. Afterwards, they already started to recognize that it was a typical post-COVID disease. So gradually, perhaps a little bit more awareness of the potential for post-COVID symptoms, etc. I started to report my conditions to her, and she said something similar to this. Okay, that doesn't matter. Let's get to the point. I don't want to hear you. I'm not going to solve all your problems today. So perhaps also signaling some inability to manage or treat this condition because there is little that is known about it. Our interviews point primarily to these negative experiences, but they also point to examples typically of doctors, medical professionals that they consider to be good, that were positive interactions, and a lot of them like signal to what we understand to be as epistemic humility, or strategies that were used by medical professionals that are that help ameliorate these accusations of dismissal. So these are doctors who might potentially acknowledge that they don't know too much about long COVID, or who might just listen, who might empathize with the patient a little bit more, who might not dismiss them outright. So these are strategies that medical professionals use to perhaps manage some of these uncertainties. We coded the survey responses for descriptions of positive and negative interactions with medical professionals. 79% of our US respondents in the survey reported negative interactions, 61% in our Brazil respondents. While there's a lot of ways to read this, right, that people typically complain more than they praise, etc. But it still, I think, is indicative perhaps of the perceptions of patients of how they're being treated. All right, so one of our second findings is this acute and chronic divide. There is potentially a double burden of disease that is particularly pronounced during the early phase of the pandemic, when hospitals and doctors and providers were juggling between dealing with the somewhat emergency and exceptional circumstances brought on by the onslaught of COVID-19 patients. We see this in the US as well too, right? Thinking about how overstretched our health systems were in 2020 and 2021. But in low and middle income countries, there have been a longer literature of the inability of health systems to contend with chronic diseases, whether it's the lack of access to medicines or the lack of infrastructures for follow-ups, and the lack of availability of specialists, et cetera. So there is a longer standing of like infrastructural concerns in developing countries that also impacts, I think, the experience of long COVID patients there. So these are some examples from our Brazil respondents. I felt that I was not supposed to be at the SASE hospital, the public health system in Brazil, because the nurse said, no, this is only for people who have COVID or the flu. If you don't have that, you're not supposed to be here. So hospitals prioritizing care for acute conditions rather than their chronic long COVID complaints. The doctors in the private hospital were not using masks, and they were refusing to take tests because they didn't want to have the hospital to have a case of COVID. So this is, again, I guess, like an allegation that is levied by a respondent. There are perhaps ways in which we can like try to verify this claim, but this is one thing that more than one of our respondents suggested, that hospitals were trying to undercount or trying to avoid testing so that they wouldn't have to invoke the emergency measures that were needed to combat an outbreak in the hospital, especially when they were already overstretched. For the Brazilian context, there is also a lot of public and private inequality in healthcare. So yeah, the public health system, SUS, is a great health system. Most of our respondents recognize that they are a important social safety net, especially for lower middle class and working class folks in Brazil. And because most of our respondents were primarily more educated, have like higher household incomes, they were able to turn to private healthcare to seek help, and they recognize kind of like their privilege and their ability to do so. So these are some quotes from our Brazil respondents again. If I couldn't pay for private health insurance, I would have had to wait 2 days to get tested in the laboratory. This test is wonderful, but it takes often a long time to make medical appointments. So I was very privileged to have medical plans to be able to do this all very quickly. Another respondent says, the specialist doctors, as it was private and they wanted to keep the patients loyal, they treated me with a welcoming attitude. Under the SUS, the specialists would take a long time, and I was in a certain urgency, so I paid for all the exams and consultations. So aside from between country inequalities, also potentials for within country inequalities as well. All right, so our last finding from these sets of surveys is the foreign local divide. We also, one of our hunches is that medical expertise and awareness of long COVID is unequal around the world. Perhaps doctors in different jurisdictions and different national healthcare systems have different approaches to dealing with long COVID, right? So this stems from a little bit to the political context in Brazil. So these are some quotes from our Brazilian respondents. In fact, our Ministry of Health doesn't even recognize COVID, right? So it doesn't even comment, so they don't even comment on post-COVID conditions. We have a denialist president and unfortunately a medical accomplice at the head of the ministry, a doctor who heads the Ministry of Health, who helped Bolsonaro at the time deny the existence of COVID or the severity of COVID. So they're saying like, forget long COVID. Another respondent says, I don't trust the Brazilian media very much, so I go after more correct information on patient groups on Facebook, science educational channels on YouTube to learn more about long COVID. So similar to our US respondents, these online support groups play a pivotal role in disseminating information, but as with our US respondents, our Brazilian respondents talk a lot about different strategies that they use to triangulate to verify the information that they see online. So they don't really take the information that they find online on face value, but they do a lot more work, sometimes collectively, sometimes individually, to vet whether or not to trust what they read about. And just this is a Web of Science search, so bibliometrics of articles published about long COVID. So because awareness about long COVID is unevenly distributed around the world, we also might expect that scientific research about long COVID to also be similarly unevenly distributed. So the US leads in long COVID research, followed by the UK, Italy, Germany, Spain, France. Brazil comes towards the very end. So there were 454 corresponding offers listed in the US versus 73 in Brazil. So there's some research. It takes a while for research to catch up to what's going on around the world, but just an indication perhaps of the inequality in knowledge about long COVID that might trickle down to how doctors, how national policies might also reflect this like unequal distribution of awareness of long COVID. All right, so some quick takeaways. These are some of our recommendations for policymakers, medical professionals, researchers. Number one, provide more support and training for medical professionals interacting with long COVID patients. This, I think, yeah, we see more and more, right? There is more awareness amongst our later respondents, interacting with doctors who hear more and more about long COVID, recognizing that it is a thing. So that is something that is being taken up, but more explicit education and professional education might be helpful to increase awareness. We also would want folks in the research space and the policy space to promote more dialogues with patient organizations, particularly internationally, to share experiences. There are definitely more patient organizations in the US context than in the Brazil context. A lot of our research was made possible by reaching out to these patient organizations who helped us recruit interviewees and survey respondents. And there were a lot more active organizations here in the US compared to Brazil. So work also needs to be done to promote these patient organizations in other countries. And there's also more of a need for global comparative research to understand how social contexts shape these different illness experiences. And I think we see a little bit of hints of that in our research so far that shows how the lack of awareness, how the ability of healthcare systems to contend with chronic conditions, and how doctors' awareness of long COVID differs. So all these things obviously shape how patients are able to access medicines and healthcare. And just flagging some of our future work, we are developing the trust piece a little bit more to think more explicitly how there are these strategies that these long COVID patients use to find and identify credible and trustworthy forms of information. This speaks a little bit more to, I think, like sociological concerns that we have. We are also interested in how patient advocates here in the US are increasingly working with scientists and policymakers. The long COVID terminology definitely is one of the fastest like disease categories that have been like codified into the international classification of diseases. So there is a lot of advocacy that's being done. So we're interested in thinking about these linkages between advocates and policymakers and scientists. And we're also more broadly interested in how long COVID might potentially be impacting the labor force and the working conditions of individuals in the US and elsewhere. There are a lot of new figures out, I think this past week, on the rise in disability claims in the US labor force from the Federal Reserve, I think, Federal Reserve probably. So there's a lot more work to be done to figure out how long COVID intersects with other parts of social life. So thank you for listening, and I will stop here.
So we'll have, I'm sure, lots of discussion afterwards. Thanks for sharing that. Ben, you want to take it away?
Hopefully you can see my screen.
Yep.
Super. Great. Okay, well, thanks very much for the chance to present this paper. If you've seen the written form on the shared Google Drive folder, you will have noticed that it's not quite complete, and the referencing gets increasingly ragged as it goes on. It is a work in progress paper. Some of the thinking needs developing. I'm hoping that that might come through in the discussion, to just hear people's impressions on the approach that we're taking in the paper, and areas that need further work and elaboration. So it's being presented with that very much in mind. The paper itself kind of makes the case for a closer study of internationalization in healthcare, using the case of the English NHS. It's something that we think can help with understanding the changing nature of healthcare and healthcare systems with the kind of expansion of globalization processes going on. We're also toying with ways of kind of advancing internationalization of a framework by embedding a stronger sense of moral kind of norms within internationalization, implicit norms, understanding or different understandings around what is right and what is wrong in an ostensibly national healthcare system that looks to international healthcare and engagements. So the structure of how I'm going to just talk about this is very quickly mention sort of overview of what internationalization is, how it's been used in other areas of work, the potential for building in a stronger moral dimension to it. I'll briefly talk about the case of choice and the methods, and then 3 sets of international activities we see in and around the English NHS, and what this might tell us about international boundaries and engagements in healthcare. So internationalization, I'm sure everyone in this call, anyone watching on YouTube, has probably come across internationalization as a concept. Its origins are usually attributed to business management studies, the idea that firms pursue internationalization strategies, kind of the expansion internationally of their business. Some people have used that kind of an approach looking at healthcare companies, how they look to expand internationally. But it's been used in a range of other ways as well within the study of health and healthcare. So health worker education studies, we see in internationalization used as a concept quite loosely to refer to the kind of broad phenomena of increasing kind of inclusion of foreign texts, conditions, and bodies within curricula. Within the study of healthcare systems, from what I can see, there's only really a very small number of studies that talk about internationalization as it takes place within a national healthcare system, particularly thinking about the entry of foreign companies, foreign bodies, foreign users into national systems. So as things stand, only really a small number that do it like that. And that's something I think we're looking to expand on with the paper in terms of that sort of approach, thinking about systems as well as organizations. And I think that's something that higher education studies, okay, it's outside healthcare, but actually does much more prolifically There's the really seminal paper on internationalization in higher education by Altbach and Knight, where they kind of set out much more of a systemic approach to understanding internationalization, looking at a range of activities across different kind of markets, the common context for this, situating internationalization really within kind of trade globalization and the commodification of services. So quite, I think important as a potential kind of precedent for how we might apply internationalization as a lens within healthcare. The other thing we're trying to do in the paper a little bit is build a kind of, as I say, a moral dimension to internationalization, thinking about norms and how those shape what is and isn't subject to the international when it comes to a national system. Here, we've been looking a lot at moral economies work. Moral economies, again, I'm sure people watching, those of you in the call, are familiar with this. As an approach, moral economies sort of stems from E.P. Thompson's work looking at so it's a historical analysis of food riots in 18th century England, looking at the kind of subordination of social concerns and norms around food consumption and purchase, and the subordination of those to commercial concerns and the kind of backlash that emerged, the rioting. So this, obviously the idea of the social and the moral within markets is actually not kind of new with Thompson. That's something you can trace back to Lanny, Smith, goes back a long way in terms of socio-economic thinking. But certainly with the moral economies approach, it's proved a very fruitful kind of analysis to thinking about norms and values within different areas of economic activity. If you search for the moral economy of pretty much anything, you will probably find some relevant text, whether X is a moral economy of a product or an institution or a sector. So it's a very widely used approach. I think some of the kind of ways it's been applied that we found most interesting or useful are by kind of Andrew Sayer and a line of thinking which really sees all economic activities as having kind of moral basis in some form. There are norms, there are values that form the basis of what is and isn't provided or consumed in the way that it is. So I think that's really the sort of, when I'm talking about the moral dimensions to internationalization, that's the line of thinking I'm drawing on. Understanding the moral basis for internationalization. What are the rules and norms around how, if, and why a national healthcare system should or shouldn't engage with the international? Applying this to the case being English NHS, the NHS, the National Health Service, again, usually quite well known around the world, but very quickly, originates mid-20th century UK, post-World War II welfare state. It is a system of healthcare provision which mixes publicly owned, or originally mixed publicly owned hospitals with privately owned primary care that was contracted to provide services. So it had a public-private mix, but was financed primarily through general taxation and social insurance. Over time, that has kind of shifted in terms of there's been greater or series of market-oriented reforms, building in kind of internal markets, greater private sector involvement in all different areas of the NHS. So it's quite a complex beast. It's also no longer a UK NHS since in the past sort of 20 years. It's become a devolved issue constitutionally, and so there is an NHS in Scotland, Wales, Northern Ireland. There are differences between them. The English NHS is the most kind of commodified of them all. Scotland and Wales, for example, have rolled back some of the market-oriented reforms, or didn't introduce them in the first place. The other thing that's important to mention is that the NHS has a very strong cultural identity in England. It's bound up with a sense of English nationalism. There are interplays with certain forms of xenophobia I'll come on to shortly. You see repeated assertions that it is a national, adamantly not an international health service. There is this kind of national bounding of the service that we see playing out frequently. So I think that's important to bear in mind when we think about actually the international processes that it connects to. And then just in terms of quickly the methods for what I'm going to talk about, it's drawn primarily or initially from a reading of key policy documents relating to the English NHS covering a 22-year period and how they talk about the international, or more often don't. That covers several prime ministers, some you may be aware of, some more than others. And we've kind of supplemented that with searches, more targeted searches of relevant think tank reports, the Parliamentary Archive Transcript Service, Hansard, press media coverage, just to get a sense of the political commentary and the sorts of debates and contestation that takes place around the borders of the NHS as a national or international set of activities. In the paper and in the presentation, I am grouping the findings into three sort of sets of international activities which are market oriented and which tell us something, I think, about the normative questions that underpin the national and international boundaries of the English NHS. So the first being cross-border healthcare users and what sort of debates and limitations around that reveals about who is seen as being able to access services in a national healthcare system and on what terms. Generally, you look at anything written about the English NHS policy-wise, and it will talk about local users, local communities. There's this huge emphasis on the local, which makes sense given politicians' interests in serving certain constituencies, including their electorate. But in doing so, it downplays the fact that there are various forms of international engagement. One being the fact that some hospitals earn quite a lot of income from treating overseas users who travel to the UK, to travel to particularly London, to access healthcare on a fee-paying basis in NHS hospitals. Historically, that has been people traveling from Middle Eastern countries with government sponsorship paying their fees, but it's since diversified more broadly. If you look back to sort of 2002, 2003, there was this big push to get hospitals in the English NHS to operate more like private entities. There was the introduction of this foundation trust status that would get, it's kind of a corporatization of NHS hospitals for those who applied to attain foundation trust status. The idea was they would have much more interest in private income. However, internal debate within the ruling Labour Party at the time led to a cap actually on how much foundation trusts would be allowed to generate from private patient provision, including overseas patients. And non-NHS overseas patients was introduced as a kind of a line in the account. So you can actually trace the amount of income going to NHS hospitals from 2002 onwards, coming from non-NHS overseas patients. So there was the kind of internal political pressures led to a limit on that, not because of the international concern, because of the concern that public organizations were acting like private companies. However, I mean, various hospitals that did a lot of international private patient work just didn't take foundation trust status, and therefore bypassed the cap in any case. But also, come 2012, you have a move towards the Conservative Liberal Democrat coalition government, lifted the ceiling on private patient income. So there was this suddenly huge financial incentive to encourage it, and some of the hospitals did that in a big way. What's interesting is that this whole process has been very rarely criticized in the sense of it triggering or stimulating the international fee-paying access to NHS hospitals, with the exception of this kind of subset described as loosely as health tourism. That in the UK has a particularly negative connotation. Actually, in a lot of health services, health systems literature, people tend not to mind health tourism as a concept. In the UK, it's actually quite understood quite negatively. And it's used as a concept to gatekeep NHS and other welfare services. There's a definition here which comes interestingly from a right-wing tabloid newspaper defining health tourism, the fact that they felt the need to define it is interesting, but here's the definition. Health tourism is when patients who are not entitled to free NHS care are treated without paying their bills. It covers short-term migrants, holidaymakers, foreigners. So there's the attention to the international, but also within that, the concern, not so much with the international in itself, but international visitors who don't pay. So the implication being, and we see this when we see the clampdowns on health tourism, where fees are introduced or expanded in terms of who is required to pay fees to use NHS services. What we see is that it's accepting of foreign bodies within NHS hospitals, but on a fee-paying basis. So this tight connection between internationalization and marketization. The second area I want to talk about is a sort of an extension of the first, a growth in international consultancy services offered by NHS organizations. Here revealing of, I think, underlying kind of normative questions around the funding of a national healthcare system and who should be paying for it and in what ways. So I've already mentioned, the NHS primarily funded through general taxation and social health insurance, but through its history, there has been a creeping commercialization within that, co-payments, for example, looking to other forms of financing to subsidize the kind of public spending on healthcare. A real emphasis that grows from the early 2000s of hospitals operating entrepreneurially, looking to generate private income in all sorts of ways, private patients being one, international private patients as well, but also a broader range of consultancy sort of services. And so from the mid-2000s onwards, you start to see a real kind of snowballing of this. 2007, Moorfields, a big eye hospital in London, opens Moorfields Dubai as I think as a joint venture, if I remember correctly. 2008, the Department of Health announces plans to launch NHS Global, which is described as looking to exploit the commercial potential of the NHS on the world stage. 2012, the London Olympics, Summer Olympics, the NHS features very prominently within that ceremony, as does Great Ormond Street Hospital. And within weeks, there is this renewed impetus from ministers saying we need to, let's get Healthcare UK, as it became known, initiated and launched as an interdepartmental government agency to promote exporting and international commercial income for NHS organizations. There's this really revealing quote that comes a few years later in 2018 from at the time, the outgoing head of NHS England. NHS trusts not only have the capability, but also responsibility to develop strategies to export their expertise and services, even, and arguably especially, when they are under severe pressures in maintaining vital services at home. So you can see there's that pressure, describing it as a responsibility when they're under financial pressures. Very little critical attention towards it in political commentary coming from the media, within Parliament. Again, just underscoring this sort of seemingly kind of common sense stance that international engagement is fine as long as it is market-based, revenue generating, somehow subsidizing local services. How am I doing for time? Okay, I'm going to wrap through this third area a bit quicker. It's about healthcare labour. So interestingly, healthcare labour and the way the NHS has engaged internationally with healthcare labour is more as an importer than an exporter, so a slightly different set of relations, but revealing of normative questions around who should work in a national healthcare system. So the NHS has been built on the blood, sweat and tears of migrant workers, people who travelled in the kind of from Commonwealth countries, from outside the Commonwealth. It's always been reliant on this. The early 2000s, there was this idea that quite open declaration of wanting to increase international recruitment, but which quickly faded amidst a wider context of xenophobia. There was a lot of blaming of foreign doctors, so this kind of particular, frequent reference to foreign doctors, foreign nurses, this emphasis on the kind of outsider, that kind of othering. of certain groups of workers who were seen as dangerous. I've got a few headlines on the right there, but also seen as taking jobs and opportunities for advancement from UK-trained doctors and nurses. And underlying this is a kind of narrative of self-sufficiency that crops up occasionally, indeed very recently, in fact, with discussions around the workforce in the English NHS. And it's something which saw international recruitment continuing, but often in a very quiet way. So not until the kind of last few years, there's not been so much of an overt push in policy terms for international recruitment, but it's been happening, and the English NHS is increasingly reliant on it. So it's been necessary, but politically quite unpalatable and generally not overtly practiced. So just to bring together a few of those thoughts, there are various ways in which the English NHS is engaging internationally, which moves it beyond being a tightly bound national health service, which sees it relying much more on international processes, typically market-based, typically extractivist in nature, seeking to extract capital from low and middle income countries. That's taking place in a context of nativism in English politics, which seeks to isolate and intimidate bodies that are deemed foreign, and to reaffirm the national border and ideas of kind of self-sufficiency within the national border. And so one of the ways we've been kind of thinking about this as we've been kind of deliberating on the findings of the work is as a kind of quite a purposeful silence around internationalization, which might well be understood through what Lindsay McGoey and others have advanced as kind of strategic ignorance. A strategic ignorance that, on the one hand, reduces the chance of a nativist backlash against internationalization processes by downplaying the reality of how increasingly important they are within the English NHS, but also which plays down the negative implications, the externalities for people living in low and middle income countries whose healthcare systems are at the negative experience, have the negative experience of the extractivist processes of the English NHS. So I think internationalization offers us a useful framework, useful tool or lens through which to look at how healthcare systems are evolving and changing. The English NHS is a good example, maybe an extreme example, but I'd be interested to see kind of how these ideas can be expanded more broadly to other sorts of sets of activities and systems. And I will end there. Thank you.
Thank you. That was terrific. Thanks, Ben, for sharing all that. And then Anne, we'll finish off with your paper before our discussion. And you're muted.
Sorry. I will share my screen. Just a second.
Yep.
So yeah, okay. So
presenter mode. Just we're seeing.
Sorry, yeah. Yeah. So I'm happy to close the presentation phase before the discussion with that paper, which is on part of my thesis research on policy supporting the development of team practice in primary care in France, and more specifically on the implementation phase of this policy, and trying to analyze the bargaining process, power dynamics during this implementation phase of that policy. So just to give you some elements of context about the French healthcare systems, because it's quite different from the US one and the UK, and I suppose from the Brazilian healthcare system. So the integration of healthcare services has recently emerged as the answer to the main challenges facing the all healthcare systems healthcare system, be they demographic with population aging, epidemiological with the rise of chronic pathologies, or organizational with growing difficulties of access to care and inefficient care pathways. In France, however, it's a corporatist insurance-based system, also qualified as a Bismarckian system, and which is characterized by a predominance of the medical profession in the organization of the healthcare system, and the states has a quite limited role in the organization and financing of the healthcare system. And in that system, access, coordination, and continuity of care have traditionally remained marginal concerns. Such principles only appear on the political agenda by the late 90s, which is 2 decades after they were initially promoted by the World Health Organization. So, and in the primary care system, which I will be focusing on, private providers are mainly private, so they don't have any kind of contractual relation with public authorities. They are paid on a fee-for-service basis, and they have a complete freedom of settlement. This is not true for nurses anymore, but for which would be at the center of my presentation. It is still true, and each time the issue of the settlement, of the freedom of settlement of doctors is evoked in the political arena, we have massive strikes in France of doctors. However, we witness a progressive regulation of the primary care sectors. First on patients, because of that predominantly a private characteristic of the primary care sectors. The government first introduced some kind of instruments that wait on patient first. The government introduced a gatekeeping mechanism in order to regulate patients' access to healthcare with the referring physician scheme, le médecin traitant in French. So patients are supposed to go to see their GP first. If they want to be reimbursed at the maximum level, then if they go to see a specialist. But anyway, they can choose to go directly to see a specialized doctor if they want to. They won't be reimbursed by the health insurance fund at the same level that if they go to their referring physician first. And then we observe an attempt to steer medical practice and not constrained because of all I explained earlier, to steer their practice and their settlement choice through some different kind of instruments. First, bonuses to settle in underserved areas, pay for performance, and also incentives for team practice. With the recognition in 2007 of new kind of healthcare structures called Maisons de Santé Pluriprofessionnelles, multi-professional healthcare centers. I would introduce with that heavy expression in 2007. So what are the MSPs? So they have been introduced in 2007, and also another law is really important because it refined the model of the MSPs. They target private GPs and private paramedics. Sometimes they also gather other kind of professionals, pharmacists, midwives, psychologists, etc. And sometimes, but that's not so common, also specialized physicians. Their objectives are mainly of 3 kinds. First, MSPs are considered by public authorities as a way to attract young GPs in underserved areas. There are many studies showing that young GP are more likely to settle in areas where there is already those kind of team practice than settle a practice on their own. Also, the second objective is to improve access to care because of this new generation of GP settling in those kind of areas, and also to improve care coordination among GPs and paramedics. And finally, to broaden the range of care service with also preventive care and educative care, and all those kind of new practices are remunerated through additional remuneration for those private professionals, which will complement their fee-for-service payment, and which will be a compensation for the time they spend on those coordination and public health activities. Today in France, we have over 2,000 MSPs, what represents almost 15% of GPs, and the majority of them enter a new contractual relationship with public authorities in order to get those additional remuneration I just mentioned. So finally, in fact, they contract with health administration at the regional level and with public health insurance fund at the local level around different kind of criteria relating to access to care, to coordination, and also to public health activities. And they enter a new kind of accountable relationship to those public partners, which is quite unprecedented in that private sector, in order to get those remunerations. So concretely, they have to monitor and report their activity and to communicate it to the public health authorities through this new contractual relationship. But in fact, some GPs had informally developed team practice before MSPs were officially enacted in the French law. So three of those GPs were cited as example in a public report in 2007 that informed the definition of MSPs in the French law. And we interviewed with those GPs. I led some interview with them, and they explained that actually I wanted to illustrate that with an interview extract. They explained that were already organizing themselves in the French territories, some of them, and that public authorities actually leverage their local initiatives because they were facing private providers. They couldn't constrain them to settle in some specific areas or to organize themselves and to develop team practice. So they find those professional initiatives. They consider it as the way to leverage it and to generalize it on the French territory. So all those elements raise finally a question of the choice of an incentive-based contractual policy, which is deeply contingent on the free commitment of the policy targets, in that case, private providers, and which largely depends on the way they will implement this policy in their day-to-day activity. So, my research question that leads that research happens completely on the ground during the implementation process of that policy, and does this new contract imply real transformation in professional practices locally? As for the methodology, I led a two-level qualitative analysis. At the national level, I tracked the emergence of MSPs and the process of alignment between governmental and professional actors around this model and the definition given by the French law. And at the local level, I analyzed the contract implementation and its impact on professional practices. And I will focus on that the local level in this presentation, since I'm really interested in the implementation phase of the policy. So there are two major schools of thought in policy implementation literature. On the one hand, the top-down approach seeks to understand to what extent the behaviors and action of the policy targets are consistent or not with the goals and procedures of policymakers. So in this perspective, the implementation implementation research should help to identify the obstacle, what impedes concretely the process of concretizing policy decisions into action. And also, those research try to identify the political and legal levers likely to influence the policy target behaviors and action. On the other hand, approach or street level perspective, which focuses on what frontline implementers actually do. The bottom-up approach highlights the capacity of different actors involved in the implementation to adapt political decisions in response to contingency and ambiguity. This bottom-up approach appears to be more suited for that analysis. First, because it's a way to understand the day-to-day action of primary care providers that implement that policy, but also because this policy is really paradoxical in substance, because it attempts to regulate a private sector by regulating on their activity and on those private actors. So so in itself, it's really paradoxical because the government preserves the provider's autonomy and discretion and try to implement their politics through their own assimilation of the policy. So that bottom-up approach seems to be the more suitable and the more powerful to lead this analysis. As for my findings, I will first see how and why the government chose a contractor policy, because it's a politically acceptable one, but it's an ambivalent solution. And then I will account for the various trajectories of MSPs and see how this implementation leads to different local responses on the ground. So this contract this contractor policy, is really consensual because it's optional, which means that it rewards those who commit to this new kind of practice, but it won't penalize those who continue to practice as usual. So this is deeply consensual because those professionals are recognized and even paid for developing some kind of organization and healthcare services that they already wanted to develop, and they are recognized for it and paid for it. So providers actually see several advantages and opportunities to work in MSPs. First, the collective practice meet their aspiration for improved working conditions. So it's a way to break away from the solitary practice of medicine, which is really widespread in France. It's also a way to better distribute the care workload among GPs working together, but also to delegate some kind of tasks to paramedics. And for paramedics, it's a way to better communicate with GPs. It allows the most recently arrived to quickly build up a patient base, thanks to the referrals and delegation of GPs. And also, it enables those paramedics to broaden their field of competencies and intervention through those medical delegation. And also, MSPs are considered as a way of attracting young GPs, which is a concern for every I met. Then it's also consensual because, as I said, it recognizes and evaluates already existing practices. Some basic criteria of the contract I presented to you already correspond to the GP's daily routine, their working hour. They were already working from 8 to 8. They were already organizing the continuity of medical consultation among GPs, etc. So finally, it's just representing financial rewards for pre-existing practices. And the last point is that that contract allows to those professionals to develop new kind of activities. For example, coordination activities, but also public health activities that could not be remunerated otherwise, and they can develop it in MSP thanks to these additional fees. So I put here an illustration, but I think I may be short of time, so I will continue. But however, through a close examination of my different cases, because I led the analysis in 6 different structures, I see that healthcare providers in MSP actually can adapt the contract. It's a generic framework really open to adaptation for professionals. So in some cases, they really manage to, with some criteria which could seem constraining, they manage to reinterpret it. For example, the contract does not strictly define what a multi-professional consultation meeting is. So in some MSPs, they are counting some informal discussion as formal meetings in order to meet the number of meetings required each year. Or for chronic diseases management protocol, even though the French National Authority of Health has published a list of validated protocols at the national level, those protocols can be interpreted in very different ways. And for instance, the protocol for management of diabetics patients involves coordination between GPs and chiropodists in some structures, and in other, it involves preventive action carried out by a nurse, for example. So it's really they can really have a margin of maneuver to adapt those criteria, and also at another level, they can even use in a discretionary way the additional remuneration to fund completely new health services. So the additional remuneration are designed to compensate for the time they spend on coordination and public health. But in fact, we observed that they were using it to develop, for example, new kind of healthcare services. I have an example in mind of a structure which developed consultation for young people to access contraception freely. So they don't make the patient pay, but they pay themselves through this additional remuneration. And this is not planned by the health insurance fund and the health administration in France. So it was a completely discretionary use of those remuneration. So I have here an illustration of that kind of a discretionary application of the contract. So they say they play the game, they tick their administrative boxes, but after they do whatever they want. And she explained the different kind of public services, healthcare services they develop in her structure. But yet, even if the professional I met explained me that finally that contract doesn't change that much what they were already doing, and they can even adapt the contract to what they want to do. Yet it's a quite ambivalent solution because it fosters, even if it's quite loose at that stage of the policy, it fosters more control from public partners private providers' practices. So these new contracts represent an administrative burden which is really unprecedented in the private sectors, because those professionals have to justify compliance with the contract and have to monitor and report their activity. There is always one provider which is more involved than his colleagues or her colleagues in that kind of administrative work. It's almost in every cases I've seen, it's always the GP who is at the origin of the project. He's sometimes he can sometimes offload part of that work to a paramedic or another GP, which also who are also committed to that kind of work. But even if in those cases, when they are able to offload part of that burden, they all say they are really tired of those activities. They don't have time for them because they have a long patient queue, and it's an additional work which is quite tiring for them. Besides, there is a kind of irreversibility to that contract because the contract has become a kind of prerequisite. It's tacit, but it's a kind of prerequisite to receive other public subsidies for professionals wanted to, for example, participate in new experiments, etc. There is also a difficulty to reconsider the contractual relationship because there is a new kind of dependence on those additional payments. Because once providers have signed that contract, for example, I have the example of structure, they hire an administrative employee on a permanent contract, and they can't fire that employee if they even wanted to exit the contract. So there is a kind of ratchet effect. But the capacity control from the public partners is quite limited, and even I've seen that they rate many adaptation of the contract. Maybe I'm too long. I see I have a message. Okay, so I will go directly at the end. So then I wanted to propose a kind of typology of structures according to their level of assimilation of the contract, and if they can use it as a strategic mean of developing new healthcare practices, or if they were in a more compliant position, or if they couldn't even sign the contract and they were in a more conflictual relationship with the public partners, but I haven't time for that. And I identified the parameters explaining these diverse local responses, and I will just finish on that. So I've seen that it depends the way they can use that contract to develop more different kind of activities they want to develop. Depends on the profile and role of the GP who is the MSP, his or her ability to share this burden with others, and also the public authorities' tolerance toward those adaptations. So as a conclusion, at an empirical level, this paper document to me a key development in the French healthcare system, which is the emergence of a new kind of organization of the primary care system. And at a theoretical level, I show that the implementation of this contractual policy depends deeply on the ability of the actor involved in this policy to find an agreement through a complex bargaining process, and also to tolerate local variation of that policy. I'm really sorry because I had more details to share, but I was too long, so I'm really, really sorry.
No worries. Thank you for sharing that.